Let me just go up to the top here. And anyone can message me on my phone if you need anything, because I will be looking at my phone. Okay. Okay, so again, I'm not going to talk about epidemiology that much. I think you all have, certainly in this audience, know extremely well that new infections coming from humans into humans is very common, and unfortunately it's really the actions that we're performing as humans that is leading to this event. So global warming with infections moving north to get more cool, lots of zoonoses coming into humans, including this one, changes in agriculture, and we're really encroaching into animal habitats, our urbanization, our jet travel, all of this is leading to the encroachment of new species into human populations, including COVID-19. And, we certainly know that coronavirus, you all remember, but that really corona means crown in Latin. And so under the electron microscope only, you can't see this in any other way. There's a lot of spikes. This is called the spikes on top of the coronavirus. And it's really that names the coronavirus as a crown. Coronaviruses are very frequent, and they're very happily usually cause the common cold. The problem is there have been 3 times in human history now, or at least in recent history that we know of, where coronavirus has gone from causing an upper respiratory tract infection, not a big deal, to these lower respiratory tract infections. We are now on our 3rd pandemic. The first one was in 2002, 2003. Another one started in 2012. And now this is the 3rd time. And unfortunately, with the continued encroachment into human habits, it's possible we'll get more. The first one that we know of in recent history was the SARS epidemic. And of course, SARS came out of China at the Wuhan province in 2002. And it lasted from around 11/2002 to 7/2003. And it caused a lower respiratory tract infection. So it caused in some adults, not in all, but in some adults, the more lower respiratory tract infections, cough, shortness of breath, fever, and even ARDS. And it lasted, it only caused about 8,100 cases worldwide. It spread to 29 countries, and it caused 774 deaths. In the US, SARS had a very minimal impact. We had 29 cases overall in the US, 0 deaths, more in Canada in Toronto especially. And certainly, like all the coronaviruses, it seems like it was the horseshoe bat from which this virus originated. And then in the case of SARS, we know it went into a cat-like mammal called the palm civet, then went into humans, and then it's when human-to-human transmission occurs that we have a problem. The Middle East Respiratory Syndrome, as you know, came out in 2012. This was the so-called MERS COVID virus. First came out in Saudi Arabia. All cases in this case were linked to the Middle East. It's went around the world for about 7 years, but again, pretty low impact in terms of its infectivity rate. 27 countries, 2,500 cases, about 858 deaths. So any of these viruses that cause the lower respiratory tract infections can cause higher rates of death. And the United States, there were only 2 cases actually of MERS, and these were from imported cases from the Middle East in Indiana and Florida of healthcare workers. The intermediary host from the bat in this case was the camel. And so what about this new coronavirus? As you all know by now, it really was reported on New Year's Eve, December 31st, 2019, from the Wuhan province in China. You can see the map here. People, this is still being actually debated, this question of the people who had initially been exposed in the so-called wet markets or live markets. But we do know that by January 7th, it was identified as a new coronavirus. It's been spreading like wildfire since, and January 30th was when it was called a global health emergency, and then by March 11th, the WHO declared this as a pandemic. So where are we as of today, as of at least 2 hours ago, because Things are getting updated and extremely fast. Worldwide, we have over 1.8 million cases, completely different, of course, than the number of cases of those prior to coronaviruses. We have over 100,000 deaths worldwide. The United States, we became the epicenter of the pandemic on March 26 at around 5 p.m. We have over 500,000 cases in the United States. There's nowhere near this in terms of other countries being affected. In fact, we surpassed any other country in terms of number of infections on March 26, and we also surpassed any other country in terms of number of deaths on April 11th. So we have over 20,000 deaths in the US. New York itself as a state has more cases than any other country outside the US in one state. So the next country below us, below the state of New York, is really Italy. And so we are, far surpassing a number of cases. And New York City alone has 104,000 as of this morning, 410 cases, and 6,717 deaths. So hopefully the Epi Talks gave you the discussion, and Cuomo just had, Governor Andrew Cuomo had a press conference this morning, that there is absolutely flattening of hospitalizations, ICU admissions, ventilator support, but it really did reach very frightening proportions in New York City, Detroit, New Orleans, Boston, Chicago, all places emerging as hotspots. And then as of this morning, California has, of a state of 40 million, 23,385 cases. And in San Francisco, as of this morning, we have 957 cases and 15 deaths. Again, not to replicate, hopefully, what the Department of Epidemiology and Biostatistics talked about this morning, so I'm only going to mention one more aspect of epidemiology, which is our outbreak here in San Francisco. I really do want to draw your attention to the fact that the San Francisco Department of Public Health put up a data tracker last Tuesday, actually, and which has been great. But one issue about this data tracker is it's important to note that our our testing rate in San Francisco has been relatively low. So this is data as of this morning that of the total COVID-19 test results reported, almost 8,000 test results, we have 957 positive cases reported. You all very well know that that took a major jump. As of Friday, with the number of new infections reported from the MSC South Shelter on Friday, as shown in a press conference by London Breed, and 15 deaths. But importantly, if we don't have that much testing being done in the city, that 957 divided by 9,661 is actually a 12% positivity rate. So much more testing has been done in New York City that the attack rate or positivity rate is actually 1 in 1,000. So it's really important to say that that we haven't had the testing rates that we need to really track the epidemic in the city of San Francisco. However, our rates of hospitalizations and deaths have very thankfully been low. And this just shows you the going up and up and up in terms of where we are with data as of this morning at 957. This data is updated quite frequently on the SFGH tracker. And then you've already heard some of these statistics already, I would presume, from this morning, but it really does seem like it's 60% male and 40% female in the city. To date, at least, to date, no cases have been reported among trans women or trans men. You can see that the age group distribution as of the San Francisco DPH data tracker on the bottom left there. And then you can see, and this is data that's just going to start being reported in a more formal way. You can see the predominance among Latino populations in our city, with that unknown category of others probably, once that's really redone, there's going to be categorization of those unknown into the Latino populations in the city. And then we passed a long time ago the question of community transmission. As you know very well, community transmission in the city of San Francisco was first reported on March 5th. Could I ask that anyone who has any questions, because I'm on my slide share, and if you have urgent questions that you want to ask me, if Rochelle or someone could text me on my phone because I want to be able to respond to your questions in real time, but because I can't hear you, and I'm so sorry about my computer, I would like to be able to answer if anyone, or can I bring up the chat? Okay, everyone's saying they don't have questions yet. Okay, but I think I'm gonna put, I'm actually gonna put the chat screen here such that if anyone has any questions that are burning, please chat, and I can see my chat screen now so that you can chat me in real time. Okay, so again, this is I think already data that you all heard this morning from the Department of Epidemiology and Biostatistics grand round. So I really want to get to the kind of clinical messaging that I can talk about as a clinician. I'm actually on COVID service today here at San Francisco General, and don't want to review the epi with you because I know that Dr. Rutherford, I'm sure, did a great job. These are really his slides. This is his slide that he presented at the San Francisco, at the medical grand rounds last week on Thursday, what it would take to return to the life we aspire to. And our transmission in this city at least needs to be low. We need low numbers of new cases. We need low numbers of hospital admissions. We need low incidence. So that's important to say that we may not know our denominator yet to be able to truly measure our incidence, right? We need low seroprevalence, and that's really going to require testing with serology. And we definitely need massive testing to be available for us to understand our true rates of incidence in the city, for example. And then we can go to a strategy once we have those categories down about low numbers of new cases, then we can go to a strategy for starting to ease some of these guidelines of social distancing. Right now, as you know, we have social distancing in the city with the health order until May 3rd. And the governor's order, as you remember, the San Francisco order was declared on March 16th. The state of California governor's order was put out on March 19th. And right now, the March 19th California order, though I believe Governor Newsom is giving a press conference right now, the California order sort of indefinite, and the San Francisco order right now is until May 3rd. So I think we need a greater handle on these numbers with testing, and we need a greater handle on what happened after the shelter system outbreak at MSC South before we get to our true numbers right now. So if we want to talk about, and I think this is really important, is if we want to talk about the clinical manifestations, all of this has been emerging. I think you can all that I think you can, I'm sorry, I want to make sure that my chat is up on the screen so that I can get anything that you're trying to tell me. But I think that you all know essentially what has been scary about any of these coronaviruses, these three that I told you about, is this ability to cause these lower respiratory tract syndromes, right? Because upper respiratory tract syndromes and having a cold with all the other coronaviruses we have not been very frightening to date. And so it's really this ability to go in the lower respiratory tract. And we have data emerging about how this is happening. There was a great Department of Medicine grand rounds 2 weeks ago from this Thursday, so 2 weeks prior, where Dr. Michael Mathey from the pulmonary department really went into the pathophysiology of ARDS, or acute respiratory distress syndrome. But we certainly don't know all of the reasons how this causes, because this is just emerging, how the SARS-CoV-2 virus causes the acute respiratory distress syndrome. But we do know that essentially it really requires viral entry, replication. It's important to say that one way in which the virus enters epithelial cells in the lungs is through what's called the ACE receptor, the angiotensin receptor, which is why there's been so much interest in angiotensin blockade in the context of this virus. And then there's sort of a process, and a kind of a massive process of acute lung injury. In that process of acute infection, myocardial events can occur, and there's been more and more data about cardiac toxicities and acute myocardial injury. Vasoconstriction can occur, vascular permeability can occur, and it's that massive process that gets us into the syndrome of ARDS that can be so dangerous. I do have a question from Larry Rand. Do we have a reasonable bottom line answer regarding the debate of whether or not folks on ARB should switch to another agent? I think we do. The New England Journal put out an article now 2 weeks ago that really went over the mechanism of ARB blockade and the renin-angiotensin-aldosterone system in the setting of SARS-CoV-2. And basically where the cardiologists have settled, where the New England Journal article, a review really settled, is don't stop people's ARBs. Don't stop their ACE inhibitors or their ARBs, because hypertension itself, as shown on the right side here, doesn't actually say that, but hypertension is a risk factor for developing severe ARDS with SARS-CoV-2. And there is some theoretical benefit to ARBs and ACE inhibitors. So right now, the sort of, I think, unified guidelines is don't start ARBs or ACE inhibitors to like fix, SARS-CoV-2, but do not stop them. And that's really the consensus that we have from our cardiologists at this point. Okay, so, this was early data, but now we are having more and more data come out of beyond what we got from Wuhan province. So this was, the data that was quoted very early on in terms of the clinical manifestations of COVID. And the reason this data was shown so often early in the epidemic is because this was a case series of 44,000 patients. So that's how much you have, going on in Wuhan that was reported from the Chinese CDC. And so that's why this data gets bandied about so often. We're having increasing case reports and data reports from ICU presentations in Italy, from ICU presentations in Seattle. And these are being published in JAMA and New England Journal as recently as Friday, the Seattle experience. And so it really, we need to put all this together and kind of come up with what are the syndromes and how do they differ in different settings. But in overall, you can say some very, generalized statements, which is that fever is a quite predominant symptom of SARS-CoV-2, at least in the Wuhan province. Huge case series. It really was prominent, almost 95%. And we're seeing this in the hospital at San Francisco General. Lots of fevers, and the fevers can actually last for quite a long time. Cough is a very predominant symptom, not a sputum cough, but a non-productive cough. And then lots of body aches. Myalgias, arthralgias seem to be a predominant sign of it. And then you'll see in the press, and again, we need to stop and catch our breath and put together all of the syndromes that are coming out, but there are a variety of syndromes that are being described. Encephalitis has been described. Whether that's great data or not, neurologic findings are being described. That needs to be put together in a really clean case series before we jump to what are the neurologic syndromes of COVID. Ocular symptoms have been increasingly described, along with conjunctival infusion, all the way to problems with vision. There have been lots of GI symptoms described, but not at high frequencies. But if anything's going to happen with the GI system, it's usually diarrhea, non-bloody. So again, it behooves us, because this happened early in the HIV epidemic, to really put together all the case series, pull out everyone who's having GI symptoms, who's having ocular symptoms, who's having neurologic symptoms, and really describe things well and carefully before we decide. Okay, I'm getting a comment, please. Oh, okay. So we have lots of questions. So that means that we should go a little more quickly. So let me do that. So let me go more quickly through this. So in terms of the case fatality, there's no doubt that the syndrome of older patients being more vulnerable has come out, again and again, whether it's from Wuhan with this 44,000 case series, or whether it's whether it's in the United States with the CDC 2.5 weeks ago publishing the data from the first severe SARS cases in the United States. So older patients having a higher case fatality rate, certainly into their 70s and 80s. And you can see here the case fatality rates out of this large case series in Wuhan. And then, you know, sort of vulnerabilities or comorbidities that are coming out that are most associated with having more severe comorbidities. The kind of comorbidities that have come out are hypertension, diabetes, cardiovascular disease, chronic respiratory disease, and cancer, just any cancer. And so, and this male predominance that we saw in the city of San Francisco has been reported in many other case series, which could be linked to higher rates of cigarette smoking in males. It could be genetic. You know, all of these need to be sorted out when we're at the beginning of a pandemic. The important thing to know about the clinical course in SARS is all of this pre-symptomatic shedding. And that really is data that's been emerging over the last really 3 weeks, that what's different about SARS-CoV-2 as compared to SARS-CoV-1 and the MERS-CoV is how much there can be viral shedding from the nose and the mouth even prior to the development of symptoms. And there have also been some case reports that that shedding is very viable, that the virus is actually culturable. And so it's this degree of pre-symptomatic shedding from the nose and mouth, not from the lower respiratory tract, which is where SARS-CoV-1 replicated and why we didn't see a lot of asymptomatic shedding. But it's this degree of pre-symptomatic shedding and asymptomatic shedding from the nose and mouth early on, before you even know if you have symptoms, that is possibly leading to this degree of contagiousness, this degree of spread, this degree of sort of unseen spread of a respiratory virus around the world. Admittedly, influenza spread a lot, the Spanish flu in 1918, 1919, but even influenza has lower viral loads in the upper respiratory tract compared to the lower respiratory tract, and lower durations of viral shedding than SARS-CoV-1 does. There's a lot of features of SARS-CoV-1 that's probably leading to these high rates of infectiousness. And the other important thing to remember is that that pre-symptomatic shedding, that high viral loads, you know, can lead to symptoms of cough and fever, but even as the viral load's coming down in the nose and mouth, there's still a lower viral load syndrome where the virus is replicating the lower respiratory tract. And so later on, even after you've developed cough and fever and felt okay, then there is a time period where a certain number of patients can go on to develop much more severe dyspnea, requiring ICU level care and ventilation. So it is that kind of lag that can happen where the virus goes from replicating the upper tract to the lower tract, that you can see sickness. And so that's another distinctive feature of SARS-CoV-1 compared to SARS-CoV-2 compared to SARS-CoV-1. As you know, PCR is really the primary method upon which we're diagnosing people. You know, for example, in the city of San Francisco, it really is a nasopharyngeal swab. Because of a lack of swabs, we're not doing oropharyngeal and nasopharyngeal at the same time. There has been one FDA test approved, I'm sure Dr. George Rutherford talked about it this morning, of serologic testing, but the IgM does take longer to become positive than your PCR test will to become positive. So the first method of screening is really the PCR test. And it matters, you know, in terms of, for healthcare workers at least, with how close you're getting with the patient. Even though this aerosolized versus droplet spread infection, I would say the debate is still ongoing. We certainly treat it in the hospital as if it's droplet spread when we're examining a patient, but when we're up close with the patient, we treat it as if it's airborne. And what do I mean by that is if we are swabbing the patient, we are doing N95 masks, full eye gear, gown, and glove. And so that really is kind of full PPE for airborne precautions for close contact with patients with COVID. And that is the current standard for healthcare workers. In terms of treatment, I am seeing that that we want to go through this quickly. So I'm actually just going to give you some pearls. And I'm going to answer this question that I just got. We've had some hiccups clearing patients after infection. We've looked for 2 negative NP swabs. We have seen positive swabs long after clinical resolution. Do we have good data that looks at viral shedding versus culture to understand the question of how long after infection people are actually infectious? Yes. So this is a great question from Eric Swigel. So yes, so we don't have amazing data. There is a paper that was initially in preprint about 2.5 weeks ago by Dr. Wolfel et al., and now it's been published in Nature. That looks at the degree of viral culture being positive as opposed to viral shedding, because viral shedding being positive could occur for quite a long time actually, but the question is how long is that virus viable, and when can you clear someone out of isolation? Though this is only one study, it's as good as we get so far, and it looks like after 7 days after developing symptoms, the viral culture turned negative. And it is that, again, small study that we're using to say, okay, if we have limited resources, we need to be able to clear someone out of isolation after 8 days after they've developed symptoms. That's, we're kind of giving it this 8-day berth, because we think the viral culture is only positive within the first 7 days. You know, I literally advise someone in nephrology on that today based on that data. And that's as good a data we have right now. Because again, the viral load can go on for a while. Okay, so in terms of drug options, I'm just gonna focus just a little bit on remdesivir, hydroxychloroquine, make a comment about lopinavir, ritonavir, and chloroquine. It's important to know that you're gonna see all these studies that in vitro, you know, ivermectin, for example, can, you know, inhibit SARS-CoV-2 in vitro. The problem with those type of studies is that ivermectin would have to be given at 50 times the normal dose that it's given to inhibit SARS-CoV-2. So it's important to wait for trial data, and I mean randomized controlled clinical trial data, before we jump to conclusions about which drugs can be used for the treatment of SARS-CoV-2. It is hard to be a clinician and not be able to just hand someone something. It's a very difficult time in human history to not be able to give them something, but that's the state of the world where we are in terms of our data. So remdesivir, you've heard a lot about, really works, you know, it's specifically an antiviral, which is why it's been looked at and it's you know, something of great interest. These are slides from Annie Lukemeyer, and I thank her for this. The important thing about remdesivir, that it is a nucleotide analog. So you would think that it has direct activity because it does inhibit RNA-dependent RNA polymerase. This is where we are, however, in the world. It is very important to say that the randomized trials are coming to an end, and we should be able to get data literally from at least Asian countries within the next week or 2. So I think it's really important to wait for remdesivir randomized trial data before we jump to conclusions from other data. You probably all know that this was published in the New England Journal on Friday. The problem with something being published in such a high impact journal is that it gets tweeted widely, and it looks like it works. This is a trial where eventually they only really could look at 53 patients, and they saw that and there's no comparison group whatsoever, and all of those 53 patients got remdesivir, and 68% of them did better. Would they have done better without remdesivir? We have no idea. There's no comparison group. So it's important to really be critical and look at data before things are tweeted out like remdesivir works. We don't know that until the randomized controlled trials. We have 2 weeks to wait. And someone just said to me this morning, Vivek Jain said something really funny to me this morning, is that when there's more authors on a study than there are patients, you need to be concerned about a study. Okay, in terms of the effect of lopinavir and ritonavir, why was this even brought out? Well, lopinavir ritonavir, which is a protease inhibitor, it does seem to, in vitro at least, also affect the protease inhibitor, not just of HIV, but the protease inhibitor of SARS-CoV-2. It also, by the way, was a protease inhibitor that affected SARS-CoV-1 and MERS. So importantly, this is where we are in the world with the data on lopinavir/ritonavir. There was a New England Journal study published. It was a pretty small study. Only 199 patients total. It was a randomized study, 100 in lopinavir/ritonavir arm, 99 in those who didn't get lopinavir/ritonavir but got placebo. And it didn't look like lopinavir/ritonavir had an effect. There are some important caveats of this study. Number one, there was a median of 13 days before people on lopinavir/ritonavir actually got their lopinavir/ritonavir. That may have been too long. 33% of patients were on steroids. It was an open label RCD, and there was a 22% mortality. So there are other studies in progress to look at lopinavir/ritonavir. There are many practitioners in Asia saying they're still using it still. I really do think that we need to wait for some of the other RCTs before we completely write it off or write it in. And then there are many more under study. These are all the agents that are under studied. If you, again, from Annie, if you look at everything that's under study, mesenchymal stromal cells is a study that we're performing in our hospital by some of the pulmonologists in conjunction with Annie Lukemeyer. Lots of, again, antivirals in study. I do need to make a comment on hydroxychloroquine, and I'm going to make it really simple and then take questions. Don't have good data on hydroxychloroquine yet. It's a malaria preventative agent. It seems to have in vitro effects against viruses, which is why it's always been brought out for viruses. It was brought out for HIV, it was brought out for dengue, it was brought out for SARS-CoV-2. We do not have good data. I'm going to put a lot of data together to tell you that we do not have good data, and we need randomized controlled trial data of hydroxychloroquine before it's mentioned by presidents, before it's mentioned by anyone in the world as being an efficacious agent. I will say that it also has some dangers, especially if you give it in conjunction with azithromycin, which is an antibacterial agent. Both hydroxychloroquine and azithromycin can prolong what's called the QT interval on an EKG. And that prolongation can actually lead to what's called torsades, and the heart can stop. So there was a trial just published over the weekend that was stopped early in Brazil because chloroquine looked like it was dangerous, actually, in terms of lethality, at least given in higher doses. So it's important to say we don't have the data on this yet, and this should not be pulled away from patients with rheumatologic disease or anyone else until we have the data. Very old therapy is to give convalescent plasma. We do this even today, but it was given in the 1980 flu. It's where you take people who've recovered, you take their antibodies, you take their plasma, and you give it to someone else. So convalescent plasma is definitely being looked at, but again, it needs studies, and we have an ongoing study that's about to launch at San Francisco General. We do need patients who've had COVID to donate blood to be able to get access to convalescent plasma from people who've had COVID. I won't talk about immune modulation because I did just get a question about vaccine research, and so I'll just end with that. We have very limited knowledge if the IgG that you develop against coronavirus is going to cause immunity, but it likely is based on other coronaviruses. But we need a vaccine because it's not just herd immunity that's going to get us out of this, but a vaccine, especially since we can't let everyone get all infected at once. That's the entire point of social distancing, because the hospital systems will overflood. So we need herd immunity with time, but we definitely need vaccine strategies as well. There are many, oh, I'm sorry, this is all the clinical trials going on at UCSF, and I'll make these slides available. There are many vaccine candidates. 2 in phase 1 trials, or many ideas for vaccine candidates. And according to Grace's question that she posed to the group, how can students help support vaccine research and the advancement of testing? I think signing up for vaccine trials right now is just phase 1, is a great way to support vaccine research. And anyone who's had COVID, the idea of giving convalescent plasma and giving blood, I think is a great idea, because we really do need blood. We're having blood shortages anyway, actually, but we do need blood from people who've had exposure to COVID. Okay, I will stop. I'm actually going to very desperately see if I can hear you. But if not, I think everything has to come through the chat.
Thank you, Monica. Can you hear me now? Probably not. I will speak for the rest, and I'm asking people to post their questions on chat. I'll chat now with you. Cecily, would you kindly pose your first question to Monica?
Sure. I'm going to go ahead and send this question directly to Monica. But for the rest of you, I can go ahead and read it out loud. So basically, Monica.
Okay, thank you very much. Try to turn on both audios and then mute one of them.
Yes.
Okay, I'm going to actually do that.
Okay.
Welcome to Zoom. Enter your meeting ID followed by pound.
Give me 1 second while I just try to sign on, and then that way I can hopefully hear both of you.
Enter your participant ID followed by pound. Otherwise, just press pound to continue. Please enter the meeting password followed by pound. You are in the meeting now. There are more than 150 participants in the meeting. This meeting is being recorded. You are muted. Mute or unmute yourself.
Is that better? Can you hear us? You can hear us. Okay, but we cannot hear you, unfortunately. Okay, we definitely can't hear you. I think you're probably muted on both devices on your end. If you could just unmute one of them. There.
Okay.
We can hear you now. Can you hear us?
I can hear you.
Okay.
Great.
There's going to be a little bit of feedback. So I guess what I would do is probably mute yourself during the times when you're not speaking. And then I think the feedback shouldn't be too much of an issue.
I think that's what we'll do. Okay. Okay, so
great. So the first.
I'm going to read the question out loud. I really do apologize. So vaccine development is still many months away. I am muted on my phone. Are the current, I really apologize. I mean, actually, I'm going to hang up my phone, and I just know that I can't hear you, and I really do apologize. I will get IT and fix my thing after this. So vaccine development is still many months away. Are there current protocols in place to ensure that eventual vaccine distribution will be equitably distributed among all countries? That is a great question. The fact that we don't even have basic vaccines distributed equally is profoundly ridiculous in 2020, and there is no doubt that vaccine distribution will have to be equitable. A lot of people in our world talk about that. It would, I mean, it has to be, and I think that's a very good question. It will be required to have equitable distribution for us to have an effective vaccine program. How can herd immunity be reached without a vaccine? The problem with that is it would be dangerous. If we opened up and just didn't social distance, many of us would become immune. Many of us would have asymptomatic disease, because 85% of people do not have severe disease at all. And a number of us will get asymptomatic disease, but it is simply too dangerous to allow the medical care system to be overrun. And so it is why the current strategy is some herd immunity, because it's by definition going to happen, and hopefully a vaccine. Otherwise, we'd have to social distance without a vaccine for 12 to 18 months. So I think it's really we are in a pickle unless we get a vaccine. There's no doubt. Currently, the strategy of the US and other health systems are to enact shelter-in-place and social distancing. What is the approach for low and middle income countries such as India? I mean, that is a great question. So it is true that, so when the Prime Minister Modi essentially told the entire country of 1.3 billion people in India, in 4 hours, you're gonna all lock down, that was a profoundly problematic statement.
Good. How was your weekend?
Can be enacted for those
just get off this. I'm listening to this Epi
and social distancing
talk.
The rich, and profoundly irresponsible without having any system in place for slums and people who are homeless. And so, as you probably all heard, immediately migrant workers started walking home to their villages in big groups because they had no work. And if we're talking about people being on month-to-month salary issues here, it's a day-to-day labor, what you earn in a day is how you feed your family for a day labor in India. So it was, he ended up apologizing to the country of India several days later, saying, we need systems in place, of course, for all the poor patients in India, poor people in India, before we just say shelter in place, because that is something where the social structure allows that for the rich. And so I think there will be a lot of herd immunity. I think there will be a lot of transmission. And because this does not cause severe disease among everyone, that may be an okay thing. I mean, let's see how many people get sick. India has been doing quite well. Modi extended the sheltering in place guidelines to April 30th, a couple days ago. And let's see what happens in countries where that will be the natural experiment, where that social distancing and sheltering in place, you just basically given, a dictum that is a privilege of the rich. And that is true of places in the United States. There's no doubt that we have inequalities in who's getting SARS-CoV-2 in metropolitan areas. It's Black predominated. It's people who can't shelter in place, people who can't stay away. And so there is, a problem where that's the main public health strategy, and you're not making provisions for people to shelter in place. Are the IgG antibodies effectively neutralizing the virus? The only way to know that is actually to do a neutralization assay, which would require viral culture, which is relatively dangerous. So we're making assumptions. Those assumptions are based on good data. Those assumptions are based on what happens with other coronaviruses. And I do think that they're going to be neutralizing, and I think it's going to cause immunity to get natural infection with coronavirus. But it doesn't mean that we don't need a vaccine, because your second question is really how long do you expect immunity to last? That immunity can wane. So it's going to be herd and vaccine. Without a vaccine, we're not going to be able to do this. So we are going to need a vaccine. Luckily, it's actually, because of these spike proteins, I think we are going to be able to produce a vaccine quite readily. But it is going to require both. And then there's a question that it seems like people in acute care suffer from cytokine storms. So yes, I mean, that is the phrase that people can be do well. They can have fever and cough or shortness of breath, and the viral load goes down in the upper respiratory tract. It settles in the lower respiratory tract, and then you can get over it unless you have some of these risk factors, these comorbidities, hypertension, cancer, diabetes, cardiovascular disease, lung disease, and that can tip you over the edge to more severe disease. And there is this question of the cytokine storm, and what that means is a profound release of cytokines and inflammatory modulators, and that's why inflammatory modulators are going to be so important to the treatment of this. And then this is a group that thinks about health inequities all the time. Inflammatory modulators are expensive, and who's going to get the inflammatory modulators? So I do think it's very important to know that we're facing a disease where We need to ensure that there aren't health inequities, and even there's a question, Dr. Sepulveda, do you worry about rich countries' protectionism? Absolutely, absolutely, absolutely. So Maria Ekstrand said, I think Modi's going to give a speech tomorrow about whether or not to extend the lockdown. And that's a really good article that we can all read about it. I mean, I think that Modi's been both praised and not praised for what happened in India. And that's a whole other talk that I think is beyond this. But there was a lot of anti-Muslim sentiment because there was a decision made that, you know, that a mosque gathering led to spread of coronavirus around the country. So I think India is an entire thing getting that we have to, that would require a whole talk. You encourage us to sign up for vaccine testing, correct? If we can do so, can you comment on possibilities for ill effects? Okay, it's true that people who work on the reason that vaccine trials, and you know how people are saying 12 to 18 months for a vaccine, that is a very important number because people who do basic biology in SARS will not say that these vaccines are going to be safe right away. And so it is really important to say that that people who have done original vaccine research on SARS-CoV-1, there are going to be safety issues with vaccines, which is why you can't just put out any old vaccine. It has to be studied. It has to be safe. Coronavirus there will be safety issues with some of the early vaccines. So it has to be the right vaccine. So there's no doubt that we have to look at the safety profile of vaccines in the phase 1 trials. What phase 1 and phase 2 and 3 are about, as you know, are about establishing safety before large phase 3 trials can become can go out there. So I absolutely agree with that question. Will COVID-19 become endemic in low and middle income countries? There seemed to be this early idea that, okay, maybe the heat is, going to affect because of environmental studies with SARS-CoV-2, that the heat would inactivate it. That doesn't seem to be true because we're getting into heat already and there's COVID spread. On the other hand, endemicity can be a good thing unless people get too sick. So I think there's a lot that we still need to know. I think, yes, I think that it's endemic everywhere. I think it's going to be one of those endemic viruses, but the trick is you can't let everyone get sick at once. That's the entire point, so that we can take care of people, we can hospitalize them, we can watch them, we can give them oxygen, we can, help them through it. And that's why social distancing is so important. I completely agree with this question that San Francisco has been struggling with its homeless population for quite some time. And it addresses that same point that we said about the poor in anywhere else, that sheltering in place and staying at home and watching Netflix is a privilege of the rich. And it's you saying shelter in place when shelters by definition have bunk beds, have limited amounts of PPE, unless we could have done two things. Number one, we could have solved the homeless problem in San Francisco way before this, because it's way more than an aesthetic problem. It's not just an embarrassment for tourism, right? Like it's something that should have been examined in terms of affordable housing and projects and building housing for the homeless way before this. So now we're in this situation. Then the second thing that people who work from the Coalition of the Homelessness would say, the minute we got COVID on March 5th, we should have moved everyone out from the shelters into individual hotel rooms. That's also not that easy. Private hotels did not open their hotels to the homeless. They didn't. In fact, they closed down. You do require some degree of medical care in those hotels. You actually have to have, because people are chronically ill, you have to have nurses and doctors there. So they, as someone told me who's leading the containment response for the homeless shelters, they are becoming virtual hospitals. So there are lots of reasons why not every single homeless person got put in their own hotel room, say on March 5th, though in retrospect, maybe faster movement would have been very helpful, because as you very well know, on April 10th, which was Friday, this was released to the media that in our largest homeless shelter, which is called MSC South, 70 patients did test positive, is actually 71 for COVID-19. Many of the vulnerable older HIV positive, for example, patients had been moved out of that system, but that's still 70 people, right? And everyone immediately got isolated in their own room, but that doesn't mean that we're not going to see effects, because staff will get infected. Staff members may work in the shelter, and they may work for Instacart too. And so I think we are on the precipice to see what happens from the shelter situation, and we had to watch the next week and a half and 2 weeks in San Francisco profoundly closely. And the DPH is working very hard. I know the containment people. They are friends, and they are doing such a good job, and they are working so hard, but we need everyone on deck to help with this. And it does beg the question, why had we not worked on homelessness before? And I don't hope this is not our downfall. I wish I could hear you, because I bet you're saying stuff like, yeah. But just keep in mind, if you're saying anything, I can only see. Jaime is saying yes. Yeah, we should. It was not just embarrassing before. It could be our downfall. But let's hope it's not. I mean, I do have to give credit that the DPH is working super hard. Any other questions by chat? Oh, there were other questions. Besides the vaccine, serum transfusion. Well, yeah, so that's, so the serum transfusion, that's the convalescent plasma, essentially. And we are starting a trial. We actually have a call at 5:30 p.m. tonight. Annie Lukemeyer has been amazing in starting up all these trials. I've never seen trials start so fast. And importantly, for our public health patients, even before UCSF, because she's the one who's doing it single-handedly. So yes, absolutely. Convalescent plasma trials, I think, going to start very soon. So I wouldn't say the wheel is being invented on the spot. I mean, these trials are going to happen. And in fact, once the word went out, people have been donating blood more often to Vitalant and blood banks. From Facebook, do smokers have more ACE2 receptors on the epithelial cells? That has been one question that's been posed about why smokers could be more at risk. And then I do have to get back to the clinical place, time check, all of that. So thank you so much. Our other areas generally doing well. You know what? I don't think we're ever going to get what we had in New York City, but our national leadership has been terrible on COVID. I will end with that statement that you are not surprised about. It has been terrible. It is embarrassing. We should have massive amounts of testing. We should have massive amounts of PPE. And I don't know what to tell you. You're living in a country with horrible leadership. Okay, I'm sorry. I have to end with that. Is that okay? Okay. Thank you. I'm so sorry I couldn't hear you. Bye.
Thank you so much. Even Monica cannot hear us. I think that was a great talk. She is a fabulous clinician, mentor, professor, and human being. Thank you all, and see you soon. Thank you.